Okay, welcome you to the opening of the spring-winter topics in orgonomy. And today we have a guest from our affiliate group in Seattle, Dr. Daniel Schiff. He's been here before, and the topic for today is energy and medication. I'd also like to thank David, Freya Silver, and Eli for the use of their loft, as usual. Just for those of you who haven't, most of you probably have the announcement, but the two following topics will be on April 24th, anxiety and substance abuse, and then on May 15th, the magic bullet, the whole concept of cure and its relationship to treatment, and Reich's views on that, and continuing controversies and issues about that. So what we plan to do today is I'm going to give a general overview of the problem and some of the historical perspective, and then Dr. Schiff will come on and present not really a case study, but a more specific presentation of the kinds of problems as it plays out in terms of the biological system and in terms of how it actually relates to questions of the energetic function in a living organism, and raising, again, some of the questions about how and why and when we use medications and what impact they have on our systems. And by medication, I think, even as a starting point here, at this point, to say that the obvious issue, and often because our work is often associated with psychiatric issues, the concept of medication, I think most people immediately respond to in terms of psychiatric medications in the present day. But in fact, I mean, the issue really is about the use of medication or the function of medication in terms of treating the entire organism. And as a starting point, always keep in mind that for Reich, and certainly for any of us who practice orgonomy and continue the work, we are really not treating psychiatric disorders and somatic disorders as separate categories. They're particular different manifestations of a central problem, which is some disturbance and an expression of that disturbance in the living organism. So with that in mind, while much of our focus will tend to be on the use of psychotropic drugs, the reality is that much of this can be discussed and looked at in terms of cardiac medications or other kinds, or antibiotics for that matter. Dr. Sobey always used to say that when you take an antibiotic, it affects your energetic function in many, many different ways. First is usually that you get a big, big push of energy because you feel the sort of relief from whatever infection is in your system, and then of course usually the system becomes more increasingly depressed. So keeping that in mind, it's a starting point, I think, for looking at the whole problem. And certainly the problem today, or the issue, the area of study today, has become broad because certainly we're faced with the sense that all disturbances of the organism, physical as well as emotional, are controllable by the administering of medications. You get an RX and you get relief. Plop plop fizz fizz kind of sensibility in terms of you have an upset stomach, take Alka-Seltzer. You have a headache, take Advil or something. And that this has become increasingly presented as a solution to all mood swings, all emotional stress, and all situational stress. One of the profound problems is and this is not, by the way, simply a problem on the part of the industry that's supplying medication, because it's not just supply that is responsible, there is a demand on the part of us as individuals who want solutions very quickly, and so there's a market for simple, easy solutions, and a willingness on the part of most of us to take what comes our way and think later about the potential consequences. The other thing, as a cautionary statement, I think, is to understand that there's a tendency in those who are still involved in the work of orgonomy or interested in it to think that medication is a villain. And I think that both Dr. Schiff and I will present, and I know Dr. Rothenberg, I know Dr. Sobey took the position of that, as did Dr. Wright, that medications are a potential tool, potentially useful, and at times appropriate, as long as you understand the full range and consequences of using a medication and an intervention of that sort. So that it is not a question simply of you have a headache, you have to work it out without any aspirin, because aspirin is a villain. This is not the kind of interest that I have in the subject. What I have, my interest runs in the direction of trying to understand what medications have in common overall biologically, and then what impact they have on individuals who use them and on our biological system. Okay? I mean, historically, the problem really doesn't become a crucial issue until after the Second World War. Interesting, if one looks at Reich's work, there are periodic and fleeting references to the interest in certain drugs or certain chemicals that might affect the state of a patient, or dealing with various kinds of physical manifestations in patients. But overall, when he looks at the use of various chemical interventions, he doesn't find that they present definitive solutions. He realizes that he understands the chemical and biological implications of various kinds of substances, but what he doesn't see is any kind of resolution or solution to underlying understanding of how the organism functions. So that up until the Second World War, Reich, who in a sense probably represents the cutting edge of what we would call at that time psychosomatic medicine, the interest in the interrelationship or the functional identity between psyche and soma, and along with people like T. Wolfe, who comes as a collaborator, are really looking at the issue of what we can understand about the biological function of the organism and its various manifestations, both somatically as well as emotionally and behaviorally. After the war, there's a profound change, and one of the profound changes has to do with something that the Second World War generated, which is the discovery that various medicinal substances, chemical substances, could be very, very useful in altering the overall physical condition and basically treating conditions related to the war. Psychiatry, remember this is, Dr. Sobey and I used to talk about this, psychiatry was one of the big victors, of the Second World War, and that psychiatry emerged as a very, very dominant discipline with a sense that it had delivered a great deal of assistance to the war effort, in the sense that it got a lot of guys back on their feet and back onto the battlefield. And at the end of the Second World War, psychiatry had pretty much a free ticket. I mean, it could get as much money, as much backing as it could. And it's really around that time in universities and various hospitals and different VA programs that the real money begins to come in to explore both brain function, neurological function. You have in many ways the beginnings of modern neurosciences start in the post or coming out of the Second World War. And it's in that they begin to experiment more aggressively with various chemical substances and begin to study subcellular structures and begin to understand the neurological system in more detail, and begin to understand the function of the immune system and the function of the biochemical manipulation of physical experience in the organism. With that comes in very, very quickly the obvious solution, which is that there's a lot of money to be made in these kinds of manipulations, and the drug companies begin to, pharmaceutical companies begin to pour literally billions of dollars very early on into the development of new and more effective medications on all levels. I mean, historically, if you're old enough, you realize that the kinds of medications that become available, not just psychiatric medications, lag far behind the development of other pharmaceutical medications. But the array of medications that proliferate after the Second World War, so during the Second World War and after the Second World War, is astounding. I mean, you talk to doctors who were trained and came up before and through the Second World War, the kinds of medications that you had available to treat any kind of physical condition were minimal. If anyone who's old enough who grew up before penicillin, usually if you had ear infections, that means if you look in your ear now, you'll find hundreds of little puncture holes. Right? Because the only standard treatment for ear infections was essentially to drain the ear, and they basically, go in and almost everybody of my father's generation had bad hearing usually in one ear. It was like a usual, sort of a... Yeah, because basically, you lived, it was just a standard condition to live with various levels of infection. That whole phenomena of the efficacy of developing of antibiotics, the impact of effectiveness in treatment of basic diseases, the whole phenomena of the vaccines against various kinds of broad-based infections of childhood, polio, the struggle to find a polio vaccine, all these things created not only a lucrative economic atmosphere, but also a sense of euphoria, or a sense that all had been solved, that we basically had disease under control and disease, on the run, along with atomic energy. All very interesting things that Reich winds up addressing in some very real terms in a more broad based understanding, but the whole sense of enthusiasm after the war that science had solved all these problems. And then by the late 50s and early 60s, you had birth control for the effective birth control, which is also a pill, also a medication, produced this a kind of euphoria in the 60s, not just with the culture in a broad sense, but a sense that one was free. One didn't have to worry about disease on any significant level. One didn't have to worry about unwanted pregnancy. One didn't have to worry about war. I mean, there was an incredible sense that everything was solved. And in psychiatry, certainly, which is a major interest in this context, there was a growing community that was beginning to say that psychiatry was useful. A lot of soldiers coming out of the war, a lot of that generation felt that now psychiatry helped in the Second World War, so it was quite legitimate, it was quite respectable, it wasn't some strange alien kind of discipline. Schools and universities had big, increased budgets in psychology. So there was a great willingness, plus soldiers were going to VA hospitals actively to get treatment. And the drug companies moved in very aggressively there. And they didn't know that much. So what they did is they set up human experimentation, which is basically the big pharmaceutical companies came in and said, here, try this medication, see what it does with your psychiatric population. Try this medication, try that medication. And a number of the doctors who developed some of the first medications began to just dump huge amounts of medication into the psychiatric populations, recovering psychiatric populations. And by the 1950s, the first generation of really effective chemicals for altering moods in addition to what was being developed in the public arena, independently of the chemical companies. But much of what was happening in the public arena in terms of the 60s drug culture really had its correlates in the development of the pharmaceutical companies. I mean, LSD originally was one of the drugs that Reich had been interested in and been aware of in Scandinavia, particularly because of its broad impact on neurological functioning and on experience and states. But among other things, Reich's, as with most serious researchers, first reaction to the results of use of LSD was that it was too unpredictable, and it didn't give a consistent and manageable approach to the organism as a whole. These were transitory states. And in a very basic sense, the problems with medication, even something like an antibiotic, is that it's transitory. So that you're not talking about in most cases, a permanent change in the overall structure of the organism, although we're learning now that if you go far enough, you can, in effect, create permanent change, not necessarily change that you want in the overall structure of the organism. So by the 60s into the early 70s, and in that respect, you're really talking about, for us, living in an age where medication has become a dominant phenomena, so much so that today the average approach towards any illness, any distress in the organism, physical or emotional, is to hit it with a medication, whether it's aspirin for a headache to a much more serious psychotropic, antipsychotic, antidepressive, anti-anxiety drug, and various kinds of medications to balance out all the side effects of one drug. So that essentially psychiatry today is primarily, for instance, a way of learning how to balance the effects of various medications. So if you give somebody an anti-anxiety drug, right, well, one of the side effects, if it works at all, will be restlessness and sleep disturbance. So the answer is you give them a tranquilizer or a sleep medication to handle the sleep, but that produces other kinds of neurological and physical side effects, which you can then medicate for that. And in terms of, of course, the economics of that is that it's as long as you keep playing it out. Dr. Schiff will address some of this on a more detailed level. As long as you keep playing it out, you can keep patients moving, or feeling as if there's some effect. Because drugs, the other thing to understand is drugs do affect us. So this is not, it's not, any people who are, in quotes, anti-medication often try to propose statements that, medications don't work, medications don't do this, medications don't do that. That's not true. They do. They do work in some context. They do have particular efficacy as well as negative effect. And part of the responsible use of any kind of medication has to be the understanding of what the pluses and minuses of using that are. From an orgonomic perspective, though, what Reich, of course, continued to do, and what orgonomy became, which is in one sense why it's sort of, among other reasons that often been talked about, marginal to the mainstream, is that Reich's concepts and the orgonomics around him, the concept that orgonomy generates about biological function and biomedical understanding of the organism, biophysical understanding of the organism, wind up being very, very, not so much opposite, but in conflict with the direction that biomedical research and biomedical practice moves on in the post-war period. Prior to the 1940s, Reich's model for psychosomatic medicine was the dominant model. The interest by people like Wolff and other younger physicians who came to Europe and then later came to Reich in New York to study was not so much in psychiatry. I don't know, some of you might know historically, Theodore Wolff who collaborated with Reich, was one of the early and very prominent theorists in psychosomatic medicine. The reason he became interested in Reich's work was not from a psychiatric perspective. He was interested in Reich's work primarily because it was the first model to become available for understanding the function of psyche and soma as a whole. I mean, the standard line, of course, in psychiatry or in popular culture is that psychosomatic illness means it's basically in your head and you're crazy. Reich never, proposed that. The proposal that Reich puts forth and that Wolff elaborates is that the psyche and soma are functionally identical, and that emotional states and behavioral states and distress of emotional and behavioral states are the result of a insult or some injury or some dysfunction in the whole organism, and so that you can't treat one without treating the other, and you can't separate these things. And it's that line of thinking that shapes the direction of Reich's research and the direction of Reich's interest, so that Reich, one of the things that disturbs a lot of people when they look at Reich's work, and was always used as a criticism, is that he seems to move from cellular structural discussions and discussions of energy and subcellular biological functions to cosmic functions, to social organisms, to social interactions, and a variety of things in between. And sort of why isn't he just staying within the area that he's supposed to? But for Reich, and I think for this work in general, there is a sense that of course there is no real line of demarcation. There's no separation in these areas. That's a false or an illusory assumption. It winds up producing a field for the creation of what becomes, in Reich's terms, mechanistic solutions. And certainly what happens in terms of biomedical research, that becomes the dominant mode. You have a particular behavior. If you can locate the physical, origins or the location that is affecting that behavior, if you can in some way alter it or change its biological status, you will change the behavior, and that's all that matters. And then you move on. So if somebody again has a headache, you hit it with an effective pain reliever, and the headache goes away, the problem goes away. The fact that this person has to do this, day after day after day is not, is not the issue. The issue is that the medication, the aspirin, the Advil, the Aleve, or whatever, new generation, works at that moment. So it's a very, very cause and effect related kind of structure that produces a sense of one disturbance, one solution, and then we'll deal with the next phenomena, 10 minutes, 20 minutes, 30 minutes down the line.
The short-term therapies are like that too. You're afraid to fly, you go to a therapist that specializes in short-term thing, and he does it and thinks that he's solved the problem.
Yeah, I mean, I think what you're going to have to look at is that again, as with short-term, there are some short-term therapies that are attempting to fulfill that model, same model that medication does. There are some short-term therapies that have appropriate response to a broad systemic attempt to make larger impact on the organism. I don't think there's any one simple solution to saying that short-term therapy is all of a particular category. But I think in principle, the idea and the demands of the population, us, is that we got a problem, I got a headache, I want relief. And the faster the better. And very often, as with all biological organisms, you don't think, most of us don't think that far ahead of what, of course, I mean, the biggest example being the recent phenomenon I talked about, the ultimate medication, which is Viagra. Right? And of course, the appeal, and the growing appeal, since it's now being marketed to women also, as well as men, only to see, was it now about 2 years since it really hit the market, that there are a lot of side effects, there are a lot of questions, there are a lot of long-term issues, which anybody understanding the kinds of model that we're working with, a real psychosomatic totality, would have predicted. And the reason that you predict potential problems and downside to this is not because one is hostile to the development of medication, but because in fundamental terms, when one introduces any kind of substance into the organism, it's going to alter the state of the organism. You drink some coffee, it alters your overall function. Now, you might enjoy that. You smoke a cigarette, you might enjoy smoking cigarettes. It's going to eat food, you know. I mean, there are consequences. You go out and have a very spicy meal. You know, later on, you know, you might be, you eat a lot of sweets. And there are consequences. These are all, Dr. Sobey always like to say, you put anything into your system, it's going to have both positive and negative effects. I mean, it has to play out in your organism. Now, in many cases, we're aware, familiar, we know what to expect, and the consequences are, the joy of a great meal versus a little indigestion might be okay. But if it becomes profound enough to keep you up all night, then you start thinking again about maybe it wasn't worth the kind of fleeting gratification. Underlying all this, again, as always, it comes back to the issue of our understanding of the organism and our understanding of biological function. And here it comes then again to the question of the nature and function of energy in the biological system. At some level in the whole atmospheric and even cosmic system in nature in general, but in terms of human or animal experience, that if Reich is correct, which I, from experience to be, supportable, that all living matter essentially is a function of pulsation, of energetic pulsation, an expression of energetic pulsation. If we are in fact pulsatory organisms, all of us, right? If we are expanding and contracting, as an inevitable and natural condition for living, then anything that we introduce into our system will have one of two possible effects. It will either enhance and maybe three. It will have either nil effect, which is unlikely, but primarily it will either enhance or facilitate appropriate maintenance of that expansion or contraction, or it will in some way interfere with it. And by interfering, by the way, it does not necessarily mean will cause an immediate contraction of the organism. Most people who tend to think about these kinds of things, even in orgonomy, have a certain bias towards assuming that an introduction of anything into the system immediately causes contraction or some sort of negative. And there's also the misconception that contraction is negative as opposed to expansion, which is positive. Reich was always very careful to say that expansion and contraction are two operative and necessary parts of a whole. They're not positive or negative in any kind of moral or behavioral sense. They simply are expressions of what the total organism does, what total pulsation is. Some substances taken into the system can produce heightened expansion. But what one must also understand about, and what we have come to understand about the nature of pulsation, is that for every expansion there is a contraction. It's inevitable. And so that one has to be aware that if one ingests a substance, it's Alice in Wonderland too, it's like, it makes you big, there's also the possibility of shrinking back in a sense. So that underlying the whole question here, the whole theme of energy and medication is what is the biological base that we're looking at in terms of the organism's function. And if the biological base is expansion and contraction, and if one has the access to substances that can interact on a subcellular level with living matter to either enhance or block or control that process, you're going to have particular outcomes. Some of those outcomes can be desirable. Some of those outcomes can be less than desirable. And the problem is that once you enter into this kind of interface with this pulsation, right, unless you know and can predict what's going to happen, you can have a real mess on your hands. So what happens in the psychiatric situation, or actually in the medical situation completely, for instance, in the treatment of various cancers. I mean, there are lots of ways of killing cancer cells. It's not very hard to find substances and materials and delivery systems for killing cancer cells. The problem is figuring out how to do that without killing, everything else and leaving the organism capable of functioning. So that we've known ways of interfacing with pathological, conditions, but not necessarily. For instance, we can kill the AIDS virus quite easily, and there are substances that can wipe it out of your system, except the system is no longer functional. So the issue is, once you begin to make this kind of intervention, is to understand what kind of disruptions you're creating, and whether those warrant the kind of interventions that one is undertaking. So in the psychiatric field, what begins to become available is a wide array of drugs that definitely can alter symptoms, can alter even behaviors. The problem is they also alter a wide range of additional behaviors that one doesn't necessarily want to target. You get effect, and what we understand is the reason for that broad range of impact is that what these medications are doing is interfering with natural pulsation from a subcellular level all the way through the to the total organism's functioning. So that, for instance, a student of mine last night was talking about viewing an interview with a paranoid schizophrenic in medical school, and she was saying how it was very interesting to listen to him talk in the interview, but he had no, and Dr. Schiff and I were talking about this last night, he had no affect. So I said, how long had he, my immediate reaction was, how long had he been on medication? Well, since 1981, this guy had been on Thorazine. And so I said, since 1981, he's been on Thorazine, you're not seeing a paranoid schizophrenic, you're seeing a paranoid schizophrenic who's been basically fried physically and neurologically for well over almost 20 years, and so that you're lucky he could even communicate. So you're not. The issue is, and yet much of what the Thorazine does is it controls some of the most bizarre and most disturbing aspects of that behavior. But we also know, for instance, that electroshock will also impact on those kinds of behaviors. The problem is it also impacts on a broad range of physical and emotional and behavioral experience. So I think in one sense, what you really want to begin to understand in this is that you cannot put something into the mix without its having a broad range of effects. And again, Dr. Schiff and I were talking about the new generations of drugs and medications that are being developed, because even the biochemical industry is aware of the fact that that you have this kind of scatter effect. You essentially, the way you try a drug is you notice that, well, this seems to work, so let's develop more effective kinds. So, for instance, the development of antidepressants was, once they noticed that you could get certain kinds of impacts by blocking certain kinds of release of various chemicals in the system. Dr. Schiff will go into more detail on this. Then they began to experiment. You adjust certain molecular structures, and you see, you introduce them again. You see they have more restriction on certain kinds of symptoms and behaviors. You introduce them, you test them, you play them out. The problem is, when you talk to psychopharmacologists, for instance, we say with all the antidepressants, right? We don't know. all the antidepressants, by the way, are chemically essentially the same. The chemical structures are basically the difference between Prozac and Paxil and Zoloft are really not, I mean, basically they're the same medication. And yet, and this is true, we have no understanding why, yet different patients react differently from not reacting at all, right, to any of the medications. There's a significant body of people who do not respond at all to antidepressants. They don't work. They simply have no significant effect. The body just basically, passes them out. To not reacting to one medication, right? And then you put them on another medication. If someone doesn't react to Prozac, you put them on Paxil, all of a sudden you get maximum effect, right, for a while, for maybe a year. And then all of a sudden they're not working. Paxil doesn't work, so you put them on Zoloft and you get some effect, but not as good. So then you try a combination. And of course, in terms of the biochemical responses, the answer is, well, by the time one or other of the medications that we have doesn't work, we'll have a new generation of medications that are a little bit different. But when you look and speak to psychopharmacologists and ask them why does it work on some and why doesn't it work on others, the answer is we don't really know. And what they're hoping to do is, again, do research to look at why or how the mechanistic functions, subcellular mechanistic functions, chemical functions operate. And in the process, develop more and more specific drugs to target more and more specific limited range of behaviors or functions that will have far less impact on the system as a whole. Problem is, if one understands, again, the nature and function of pulsation and systemic function, right, of organisms, there is no such thing as isolating one cell and interfering with that cell and it not having any systemic impact. Because if you change something over here, right, it's going to systemically operate inevitably, maybe slower in some cases than faster. So it might be, for instance, more effective to develop radiation techniques to go after a cancer that pinpoint a tumor very, very tightly, right? But it's still going to interfere with the system as a whole, maybe not quite as massively or pervasively as just broad-based radiation hitting the organism. So that the issue is whether you're developing systems that enhance energetic function, right? By enhancing, meaning enable energetic function. And the problem is, by all indications thus far, medications, any kind of medication, tends to impact on energetic function. But I know of no existing medication that does not in some way block or interfere with the natural expansion and contraction of the cellular structure. I mean, in effect, when one looks at how medications work biophysically and chemically, is essentially to interfere with the cellular functions. I mean, that's the basic object in terms of either controlling substances that cells need by either increasing or decreasing flow of particular substances, chemicals, to that cellular structure, or blocking the output of whatever the particular cell is generating. So there's always some attempt in the medical chemical model to block function or to interfere with function rather than to facilitate or create environments for enhanced function. Question is whether there's any way to really solve this. Most medications, particularly psychiatric medications, most people will describe is what they do to a large extent is they remove the most disruptive aspects of a particular condition or state, or psycho-emotional, even physical state, by dulling it, by essentially affecting the level of energetic push in the system, and then essentially behavior becomes moderated, so that one doesn't feel the kinds of extremes of various disrupted states. The problem is all patients who go on medications, after the initial sense of relief that your anxiety level has been reduced, and so you're not feeling panicked or anxious, the next reaction, long term becomes like, gee, things seem duller, things seem less, full, less productive. Now, in some instances, that's a reasonable trade-off, because you haven't been able to get out of bed, and you got something that gets you to a point where you can get up, get to work, carry on, a relatively normal daily life function. That's appealing, and one shouldn't be dismissive of that. The problem is that's not necessarily long-term solution. So most patients who go on long-term psychiatric medications will get to a point where they begin to hate the operative state, even though they feel completely dependent on the use of the medication in order to even be minimally functional. And in fairness, the problem is for us as therapists, and certainly for us working in this area, like you say, is that unless we have something to offer that works a lot better than that, we're faced with the fact that you can't just simply dismiss it out of hand. Now, in terms of treatment, we do have ways of treating many of these conditions that work. The problem is they're more long-term, they're more, they involve maintenance, they involve long-term interventions, they involve time and effort and money in ways that are not necessarily economically that efficient or productive, and therefore it's hard to offer that kind of alternative as a equal appeal, with equal appeal. It was much easier in the generation that some of us here, some of you younger, some of us older folks, come of a generation where there wasn't much alternative, at least offered alternative. So it was appealing to say, well, anything helps, is fine. Today, the average patient, I've talked to a psychiatrist, the average patient comes in feeling anxious. They don't want to hear about how they could go into long-term psychotherapy to resolve the issues and work through and learn how to manage their anxiety and learn how to function. What they want is what the industry has told them, which is that take this pill and the anxiety will go away. And to some extent it does.
I have a question. It was my understanding that the generation of pills that are the serotonin uptake did not go. I mean, that what they did was restore a balance in the brain by activating some sort of serotonin uptake, so that it more closely resembled the serotonin in the brain that did not have depression or whatever.
They're not sure.
Pardon me?
They're not sure if
They're
that's
not
what
sure.
happens.
I see.
That's what the marketing. If you look at the actual
I was
literature.
involved with the marketing, so they talked as if they were absolutely sure.
Well, they always talk as if they're absolutely
Right.
sure. They're absolutely sure that Prozac has no negative side effects until somebody. Yeah, but if you looked at the literature, the actual research studies, they're not sure what happens. They know that that in some way interferes with or affects serotonin uptake. But how much, why, and what finally happens is not clear, and that's exactly the problem. Part of what Dr. Schiff will talk about is that when you go into the long-term neurological studies, the long-term neurosciences, what neurosciences are uncovering is that we're not sure, they're not even sure exactly what serotonin does. I mean, they sort of understand it, but what the full ramifications are and what normal uptake and normal levels are very, very hard to determine. And there have been studies that show that simply that getting someone to relax can affect serotonin uptake. Right? And you can affect various biological states. And this is something, of course, that anyone working in any of these kinds of areas, like certainly in bioenergetic research or work on clinically with patients bioenergetically, and even the longer traditions of yoga and various kinds of Eastern practices has known that you can create biological changes and reading simply by various techniques of relaxation or exercises. Exercising. Why does everyone like to exercise? I mean, in addition to getting your bodies, into some image that society says they should be in, but basically people enjoy physical exercise, physical activity, because it creates changes in our biological experience, and that means chemicals are released. What's so exciting about sex, besides the fact that it's one is aroused, one feels charged, or one feels discharged from pleasure. But what happens biologically is what? Just the kinds of things we're talking about. There's changes in various chemical levels. There's, if one looks at what happens to cells after sex or before sex, there are, again, these are natural biological processes. Again, medications aren't inherently the problem. The fact that if one can affect changes in chemical levels in the system, even Reich was interested in that. The question is, one, can you understand them fully? Do you know what the ramifications are? Are they predictable? Right? And are the long-range effects on the organism essentially enhancing as opposed to, and permanent, as opposed to altering and damaging?
On the other hand, you could say that any medication that arises out of the false understanding that anything at all originates in the brain, which causes anything, is doomed to fail.
Well, again, that's a perfect question as a way of introducing Dr. Schiff and Dr. Schiff's part, which is what Dr. Schiff will do is present on a more detailed level the effects of medication and the fact that psychotropic drugs ostensibly target and are designed, and the thinking of psychopharmacologists and neuroscientists is to develop ways of altering brain perception, altering brain function, altering, and in effect, as Dr. Schiff, I think, will elaborate on, affecting the way we see the world, literally in terms of ocular function, the way of engaging the world through our vision, through our perceptive capacity, and by altering that, right, affect perceptual sense of different states of experience and being and behavior. And the problem is that there well might be some faulty reasoning in back of the whole thing, which has its origins in mechanistic understanding of how the brain works. The interesting thing historically, just as a little end note to this, which I like to do when I teach this at the university, is, the understanding of the brain was not considered the organ of consciousness and conscious perception and thought until probably about 150 years ago, really actively. Prior to that, our perceptions of what, when they looked at the brain, when they did dissections and looked at the brain, most serious scientists who would be anatomists realized that it couldn't possibly have any really significant meaning. It looked too gray and dull and uninteresting. It wasn't as interesting looking as the other organs in the body. And so in one sense, it was the last area to be penetrated in terms of understanding its physiological functions. And the way it's been studied and dissected and understood is to really look at it in terms of mechanical functions of the brain, which are very consistent with a kind of Western sense of that everything has cause and effect. So essentially, it's the computer model, which is essentially brain is stimulated, brain acts, and everything else that you feel is a result of that. The ultimate model for that is, if some of you know who Sir Francis Crick is, the guy who discovered, basically one of the people, the key figure in developing the understanding of DNA and the double helix. And you might not have heard of him much, and we won the Nobel Prize for that. The last 30 or 40 years, 30 years or so of his life, he's been basically involved in brain science, in brain studies. And he has sort of staked out the most extreme positions on that. And his position now is that everything that's going on here today in consciousness and is really just a misfiring of a neuron, in the brain, and there's excess energy as a result of that. And since the brain has to do something with that excess energy, it creates narratives and stories and creates, morphs and things to distract us. But the only thing that's really going on is that our brains are overloaded with a lot of energy, so that if one can begin to affect it, we can solve it. What? It may well be, and actually that becomes the lead into what Dr. Schiff is going to hopefully elucidate on in terms of understanding the role of the brain, both, and again, there's sometimes a bias among people interested in these kinds of issues that we're addressing today to think of the brain again as the thing that you want to get away from. The issue is it simply is a vital organ, no different than other vital organs in the body. And more of the research evidence in natural studies and biological studies, and physiological studies and behavioral studies, is that the body literally thinks as a totality. So it's not just the brain. Some of a lot of the information about being physically present in the world is not necessarily always processed through the brain. There's a lot that goes on in our bodies that the brain doesn't necessarily process. It doesn't have to. It only has to process, a certain level of information to create behavior and create, solve problems. But the rest of our bodies function quite, well without a lot of input or a lot of direction from the brain.
Isn't that from a specific part of the brain that's prehistoric?
Maybe
something to that.
Yeah, maybe. But the issue is that a great deal of our organism is not simply a projection of brain perception. And that's very hard for most of us to understand. We think we have to have some overall overriding consciousness of everything that we do. And certainly what medications do is target kinds of feelings or sensations or experiences that are cerebrally processed in order to create the sense that those problems no longer exist. Now, what we understand in terms of orgonomic treatment, for instance, is that you can take any number of things to get rid of, conscious, experiences, to block them, but that doesn't necessarily mean that the long-term impact on the whole system is gone.
Well, that they're still not there because of the block.
Right, that's right. So on that note, let me first any specific questions to anything I've said, and if not, we'll go to Dr. Schiff, who will do a presentation, and then we'll take a wide range of questions. What is group A about James?
Yeah, it's okay. Do whatever you want to do.
That's a lot. I'd like to talk today about looking at some of these the actions of mostly psychotropic medications from an orgonomic perspective. And it's very fascinating, and it's been fascinating for me to research this. When I was studying a lot of my neurophysiology, which was mostly when I was doing my doctorate, which was 15 years, and when I was studying 17 years ago, I enjoyed it very much and thought I knew something. And then in coming back to this and realizing that the text I used was totally obsolete, just like a computer, that you bought a year ago, that the growth that's happened in terms of understanding neurophysiology is just enormous. I think that might be said across many disciplines of science. What was known about brain function in 1980 is infinitesimal to what's known now, and probably what will be known in 10 years' time. So in one way to say then is that anything we talk about now in terms of psychoactive, psychotropic drugs is really as it's functioning now. We don't know how it's going to look later on. And psychopharmacologists really believe that there are going to be radical changes. What that's going to mean in terms of treatment is, again, an unknown. And how that's going to play into an orgonomic treatment and be understood from an orgonomic perspective is also maybe an unknown. So to begin, I'd like to go to what Dr. Lewis was saying, and something that I think from an orgonomy we have to hold continually in mind is that this idea of pulsation and the relationship between bioenergetic pulsation and health and function. Reich later on understood that pulsation, orgone pulsation, is not restricted to that which is living. The orgone energy itself pulsates. In the living, it takes on a specific quality in terms of encompassing mechanical tension, charging, discharging, relaxation. And the organism continually has different kind of cycles of pulsation. So right now, we have a respiratory pulsation. We have a heart pulsation. We have our sleep-wake pulsation. We have our capillary pulsation. We have neuronal pulsation. On a broader scale, we have our orgasmic pulsation. There are different pulsations that occur. From Reich's understanding, if the pulsation is functioning freely, as nature intended it, which who knows exactly what that is, but if it was functioning freely, the organism would be functioning as healthfully as possible. So, of all these pulsations were freely, without restriction, occurring. And further, Reich felt that they influence one another. And of course, the whole idea of the orgasmic pulsation, the function of the organism, is to be able to discharge the energy sufficiently so the other pulsations work. So, energetic pulsation is the core. I mean, when I'm working with patients, I'm always thinking of energetic pulsation. The other thing is that energetic pulsation, the other thing that energy does is it flows. So, when Reich understood all the functioning, he was understanding functioning in terms of energy flowing. And if areas are restricted, if pulsation is restricted, that blocks energetic flow. And as probably you all know, what we experience in our lives is dependent upon this energetic flow. Our emotions, our sensations, one would say our thoughts, our ideas, our fantasies, are all expressions of this energetic flow. So, pulsation, energetic flow, health, experience, contact with life, with ourselves. Now again, what Reich said is that, and we understand, is that if the organism is insulted in some way, and I want to say in some way, because it's not just a psychological insult, but it could be a physical insult. If the environment is not conducive to energetic pulsation, the organism is going to contract or armor. And armoring is a chronic state of contraction. Usually muscular, at least on the outside, but all the organs contract. Visceral contraction, tissue contraction, essentially plasmatic contraction, which is sustained. And Reich goes into that in terms of why the organism, or just that the organism does, as you would see in an amoeba, contract and remain contracted as a way of protecting itself. So, our organism contracts we become armored. And if you remember, if you've read Reich's work about the armoring, if you look at the organism as being like a worm, and energy flowing up and down, we contract against the energetic flow, like perpendicular to it, in a longitudinal fashion. So, this is the organism, okay? And energy flows. There will be a contraction, which you saw as a ring. And if this was a worm, and you pinch the worm is going to start struggling. Each of the ends, the parts of the worm, is going to have their own independent movement. Energy flow is going to be restricted. Energy pulsation in that area is going to be compromised. And that's going to affect the energetic condition of the other areas. And Reich, in terms of working with individuals, began to see that you could conceptualize the armoring in terms of a segmental topography. And that he saw that he postulated and saw, and we work with 7 segments, functional segments that do block this energetic flow. And by functional segments, meaning they were related to the areas that mutually or work together to express emotion or stop emotion. So he spoke about the ocular segment, the oral, cervical, thoracic, diaphragmatic, abdominal, and pelvic segments. And he thought, and we work with, that if these segments are free, then energy flows freely, and that allows for the orgasmic reflex, which then allows for the regulation of all the other pulsations. So, we have these segments, and though, right, you look at it in terms of a ring, the segments are whatever is included within the ring. So, we look at the chest segment, the thoracic segment. It's not only the chest or the back musculature, or the musculature on the outside. We're talking about lungs, heart, trachea, down, esophagus, everything inside. And that works for all the segments, including the segment that Reich began to focus on much later, in the late 40s, as such a vital segment to work with in therapy, the ocular segment. And if you look at the ocular segment, you think of it, what's inside? The brain. Now, though one would think that, well, you have this worm, you have this squeezing, well, then the armoring should be equal all over the place. That isn't the case. Actually, it's much more complicated. One could be armored in one part of the diaphragmatic segment and less so in the other. Very often I see, and maybe you've experienced, that one side of you is tighter than the other. Or if you experience something, if you breathe out, you feel energy on the right side and not the left side. Or on here and not there. Some parts tingle, some parts don't. Why? Well, some parts may be more armored than other parts. Energy is going through. And depending on where the armoring is, in those areas, there'll be more of a decrease in the pulsation. So what Reich, later on, as he was beginning to speak in these terms, named this kind of disease or disease processes that result from a diminishing or restriction of pulsation, he called them biopathies. And biopathies are any kind of functional disorder that is a result of autonomic restriction and a stopping of pulsation. And the biopathies will be found in those areas where there is armoring. So he began to conceptualize, let's say, hypertension. Conceptualize that hypertension was related to armoring in the thoracic segment. The heart blood cannot get to the heart, or is restricted. The heart has to pump more vigorously, there has to be more pressure. If the armoring is relieved, energy moves through, and you have a decrease in hypertension. So let's apply that then to the ocular segment. The ocular segment is restricted. If there's armoring in the ocular segment, you're going to have disorders in the functioning of the brain. And depending on where the armoring is, it's going to be disordered in different areas of the brain. Now the brain is so complex, and there is so much interrelated going on in the brain that the whole concept of what armoring looks like in the brain is just, it's just a very kind of staggering. Mind-boggling. Now, Wright really began to speak about this when he worked with his schizophrenic patients. And I'll just read you very quickly from his chapter on the schizophrenic split in character analysis. He said, "I did not urge her anymore that day." He's talking about the treatment of this woman who he helped tremendously with intensive hormone therapy. Very fascinating case. But one thought stuck in my mind and did not budge. Is it possible that the schizophrenic attack or process is locally anchored just as other disease symptoms such as anorexia or a headache or cardiac anxiety? Is it the base of the brain, the region of the crossing of the optic nerve? Would it be reasonable to assume that schizophrenia is a true brain disease induced by some specific type of emotional upheaval with a local contraction of special parts of the brain due to severe anxiety? It's interesting that, you know, at that time, just in his clinical intuition, he placed it at the crossing of the optic nerve, which, you know, is where the hypothalamus is, you know, which regulates autonomic activity. And if you go back, parts of the limbic system, which are very much now associated with emotional situations. Minor symptoms in schizophrenia seem to confirm the validity of this assumption. The look of the schizophrenic in his eye, the degenerative processes in the brain found in old schizophrenics. And then he says, they would be secondary structural changes in tissues due to the misuse, just as calcification of blood vessels is due to chronic anxious contraction of the vascular system. So, in any biopathy, under conditions of continual contraction, the tissues themselves, the structure itself begins to degenerate, just as Dr. Lewis was saying with Thorazine. Okay? You know, how are you going to know that the person's affect is because they've been under, you know, all this medication? Well, it's a similar problem when looking at the brains of schizophrenics who have been taking medications for many, many years. How do you know if you see, you know, a smaller ventricle that it's actually due to the schizophrenic process or due to medication? Wright would have said probably it is due to the schizophrenic process because under those areas of contraction, the tissues themselves are going to end up contracted and no longer functioning in the way that they should be functioning. So it seems to me, just from this way of looking at it, that whenever we're talking about psychoactive drugs, psychopharmacology, we are really speaking about what are drugs doing to the ocular segment, and how do we understand their function in terms of that influence upon the ocular segment. And the ocular segment in orgonomic literature is seen as the most, or of vital importance in terms of the overall energetic regulation of the organism. In fact, that is one of the reasons why in orgotherapy, you're always trying to free up the ocular segment and work with that, and that without that segment, without the person's ability to make contact through their eyes and sensorium,
With what?
sensorium, their senses, ears, even smell. Without that ability for the person to make good contact, you don't want to go any further. You don't want to work with deeper emotional issues because the energy that has to be integrated in the brain is crucial to be able to go further. So, with that as a base, let's talk a little bit about some principles of psychopharmacology. And essentially, the drugs that we have now, the antidepressants, anti-schizophrenic medications, anti-anxiety medications, are essentially working on what may be considered the classical neurotransmitters. The neurotransmitters that were first discovered in the 1970s, 60s, and at that time were thought to be the transmitters. Recently, it's been discovered that there are multiple neurotransmitters of different types. And that many of them, it's unclear what their actions are, but that they do influence one another. So, as Dr. Lewis was saying earlier, we don't know what serotonin really does. Well, in some sense, we know that if you have more serotonin, it changes your mood. But exactly how it does that, though the literature might say depression is a serotonin disorder, that's misleading. It's unclear. It's unclear because there are so many other processes going on, so many other neurotransmitters that may be involved, so many other feedback loops that are influencing, that that statement is too simplistic. It's a statement that was understood in the 70s and felt to be true. It's a statement now in the late 90s that is known to be untrue. So here, we have a cell, a neural cell. Another neural cell. And essentially, the neural cells, the impulses from the neurons are communicating with other neurons, which are providing all the information and energetically influencing one another to have us function as we function now, or be part of that. We have an impulse that's coming from the center to the periphery via what's known as an axon. It comes here, and as is understood now, in one form of neural transmission, and not the only form, one form, there is a synapse, a synaptic cleft here, an area of separation to the dendrite of the other cell, or another cell's body, which will further the communication. So, you have a moat. Okay. How does the impulse cross the moat? Well, it used to be thought that the impulse caused the mole, just it jumped over it. But it was then understood that it didn't do that, at least in this kind of cell. What it does is it releases chemicals, neurotransmitters, from the end of the axon, which then binds to the receptor sites on the other cell, causing, by a very complex mechanisms of which is not really fully understood, and fully, maybe not even halfway understood, causes other mechanisms to depolarize the next cell, and on we go. It is here that most of the neurotransmitters, in fact, all, not the neurotransmitters, the psychoactive drugs are working. As one could see, and we'll talk about how they work at it, there's lots of other stuff going on. This is just one area, an important area. It's here that the drugs are influencing. And depending on the type of neurotransmitter and how it functions, the drug is going to, in a number of different ways, influence what happens to that neurotransmitter. So, in the case of the treatment of schizophrenia, it's a treatment, it takes a working to undo schizophrenic symptoms. They pretty much base it on that too much dopamine in the system causes these symptoms. There's an excess of dopamine. Now, the reason why they say that is they haven't really measured that there's an excess of dopamine because they don't know what kind of baseline levels there are. But if you stop the dopamine from affecting the other cell, you decrease the schizophrenic symptoms. Therefore, it's an excess of dopamine, or that's what's said. It may not be that. It may be there are some other feedback devices that are going on. So what happens here? What happens here is that they work to prevent the dopamine from spilling out. And the antipsychotic medications will do that. If there's no dopamine, if they prevent the dopamine from spilling out, then it's not going to affect. Actually, most of the antipsychotic medications work by blocking the dopamine from affecting the other cell. They sit in the neurotransmitter's receptors. They take a place, and therefore, it cannot affect them. The antidepressants work in another way. One, they're targeting a different neurotransmitter, which is serotonin and norepinephrine. These days, the big thing is serotonin, though many of the antidepressants work on norepinephrine, both on serotonin and norepinephrine. Some work on serotonin, norepinephrine, and dopamine. And again, as Dr. Lewis was saying, different people react differently to these different medications. Some actually do better if norepinephrine is included and blocked, whereas some do better if it's strictly serotonin. Why is that? Some need dopamine to thrown in, even though it's unclear why dopamine has anything to do with affective disorders. What the reuptake inhibitors do is that serotonin is thrown into the system, and then there's a natural process by which serotonin is taken back into the system in order to resynthesize the serotonin. What the blockers do is that they prevent the serotonin from being taken back. So you have more serotonin in the system, so you've increased the amount of serotonin here that is going to affect the next cell. Therefore, they'll say that there's a depletion of serotonin. Again, they don't really know that. All what's known is that if you have more serotonin here, that's going to lift your mood. Now, right in this area is where all these neurotransmitters are made. In fact, this is a factory. The cell is a factory. All the classical neurotransmitters are made pretty much at the end. Now, how are they made? Well, the nucleus, and in the cytoplasm here, sends the material, it's called axonal transport, down the axon over here. And there are very specific genetically encoded enzyme-related interactions that lead to the development of the neurotransmitter. And then afterwards, it comes back, redone again. One would see from this that it could be possible that these neurotransmitters are not being made right, or if there's something wrong with the axonal transport system. If for some reason these elements are not there in sufficient number, that could affect the development of the neurotransmitter. That system is not really that targeted at this time. It's not targeted because it's not fully understood. It's not targeted because this is much more easy to work with. Now, just a little more on neurotransmitters. There are some neurotransmitters that aren't created here, but they're created here. These are called peptides. It seems that there are about 50, 60 peptides. It also seems that there are other processes of neural interaction. There are many cells outside of neurons, different kinds of neurons, called glial cells, glial, G-L-I-A-L, cells, or interneurons, that were originally just thought to support the cells. And they communicate just through communication of electronic impulses. The name for that is emphatic signaling, or gap junction. This might be what happens when ECT is applied. The whole system suddenly is expressing itself. And these cells make up about 60-70% of the cells in the brain. These interactions also affect what's happening in the synapse. The other thing that affects what's happening in the synapse is hormones that come in through the bloodstream. So there are a multitude of effects, and there are multitudes of many different ways in which information is being processed. So, what does this all have to do orgonomic? Well, again, think about cellular function, any kind of function, and the whole idea of pulsation. And this, I'm taking some of these ideas from some interesting articles that Charles Konya has written in the Journal of Orgonomic, starting from 1980, 79 on, written some interesting articles on brain function. He speaks about the whole idea of brain pulsation. He speaks about one area is this whole pulsation and movement that occurs down the axon and up the axon. This whole axonal transport system, though not, again, fully understood, looks a lot like and works a lot like a worm. In fact, they say, what did they say? It works in a wave-like formation. That these vesicles of chemicals and enzymes slowly go down. They seem to know where to end. And they slowly come up. Some go faster than others. There's fast transport and slow transport. They seem to have their own little corridors. It's very fascinating. right now in neurophysiology, they speak about little motors that are moving these things along. It's very mechanistic, very motors. But however it actually works out chemically, it really seems that this is a pulsatory movement that is occurring. What happens if there is energetic restriction in the neuron, in this whole system, and this pulsation is inhibited? What happens to the chemicals involved? What happens to the neurotransmitters or the creation of the neurotransmitters? What happens then to the receptors on the other side? We know, or we propose, that seeing that the brain and neural cells work as in a similar way, though with their own specialized way, than any kind of cells in the body, that restriction is going to affect the whole metabolic process that's occurring. So we see here one form of bioenergetic pulsation that's intricately linked to the whole process of neuronal communication, and which affects and will affect the neurotransmitter process and the whole process of mood, which psychotropic drugs are trying to speak to by chemically introducing a drug to undo the imbalance, so to speak, but is not trying to change in terms of this pulsation. The other thing that's important in terms of energetic pulsation or the whole energy is that the brain and the ocular segment uses an enormous amount of energy. The brain is only 2% of the body weight, but it uses 20% of oxygen consumption. It uses 25% of glucose, which is the major way in which it develops energy, by oxidizing or changing glucose. Oxygen, glucose, is all brought to the brain by the blood supply. And there you have the other thing about how the whole energetic physiology of the brain could be influenced in terms of armoring. One, we know, not only in terms of how the blood supply could be diminished by contractions in the musculature, which then is going to lead to changes in blood flow, but also in terms of the respiratory disturbance that Reich spoke about that happens with all of us in terms of armoring. We have restricted breathing, restricted, therefore, oxygen intake, restricted, therefore, potential energy to the brain, which is going to affect the pulsation of these cells, this aspect of pulsation, and therefore, this whole process that's going on here. Now, actually, seeing that we really know so little, there's probably many other things that are going on, processes that are going on, disturbances of pulsation that are going on, that have yet to be either discovered or really elaborated on. And I just, I have this little paragraph here from this book called Receptors, which is a popular book on neurophysiology. And it's quite interesting. He doesn't give a reference for it, but he says a particular fascinating area of research involves changes in the size that proteins routinely undergo at a molecular level. And proteins, the receptors, those parts over here, are made up of our proteins. Like all matter at room temperature, the protein molecules that make up the brain exhibit vibrating motions due to thermal energy. When large groups of atoms in the brain protein move in unison, physicists refer to the process as the, quote, breathing of the protein molecule. Thus, A complete description of a protein includes not only its static three-dimensional structure, but a description of its fluctuations over minute-time dimensions. These, quote, breathing motions, it's fascinating, I mean, that's why it grabbed me, this thing looks like breathing, play a major role in the functioning of the proteins and affect such processes as the binding of neurotransmitters at their receptors. In other words, on the protein level, there could be pulsations affected by the energy in the organism. And those pulsations and restrictions are going to actually influence how neurotransmitters bind or don't bind, which is the whole major aspect of this process over here. In that sense, we know very little. Exactly what energetic restriction does on the cellular level, and maybe on the microcellular level with the proteins itself, and how that affects the general functioning of the brain. So, given that, what does this all mean in terms of medications and therapy? Well, from my point of view, what it means is that the psychotropic medications are influencing aspects of brain armoring, of ocular armoring. And they are attempting to correct those things we understand, or we don't understand, or understand partially, by introducing the neurotransmitter that seems to be deficient, or isn't working right, because of these other processes of which is not understood. And in doing so, they influence the ocular segment. For me, there's no doubt about it. A person who's very depressed, usually their ocular segment is really contracted. Take an antidepressant, it works, and there's energy in their eyes. It's right there. Unfortunately, when you take away the antidepressant, there's no energy in their eyes. So what does that mean? That means that it hasn't really influenced or changed the basic biopathy. It's just altered this part of the functioning. And it is necessary to keep this part of the functioning altered. Again, we don't know what that does in terms of the overall bioenergetic pulsation of the brain and how that will affect it. It has to affect it because everything is so interrelated and there are so many connections. So, as a temporary basis, it works. But it is not a cure. The problem is also, though, that, and as Dr. Lewis is saying, that in reality, for many disturbances in the ocular functioning, there is no good cure. I mean, we try to influence ocular functioning, helping emotions come through, helping a person be able to tolerate greater energy. The ideal being, as you do that, there's greater expansion, okay? The armoring diminishes, the pulsation returns. Theoretically, the neuronal pulsation will return, and if this is actually a pulsatory movement, then this will restore itself more to a natural process. We try to do that, but it is difficult. And in some individuals, because of the degree of armoring, and when that armoring occurred, it's only possible to a certain degree. In those cases, antidepressants have been very helpful. We know that antipsychotics have, to a certain percentage of people, been helpful. And given our state of both orgonomic knowledge and neurophysiology, probably the best that can be done. So, it really seems that psychopharmacology, to wrap this up, really seems that psychopharmacology is influencing the ocular segment. Influencing at times the ocular segment in a way that, for a possible time, orgonomic treatment can't. But hopefully, orgonomic treatment will, and then the psychopharmacological agent can be taken away in order for the full pulsation to be restored. while the person is still taking medication, we can't fully restore the pulsation because it's not natural anymore.
In fact, it might well be the case, which is not just orgonomic, and we're seeing this, although in psychopharmacology it's not understood quite, is that what tends to happen is the more dependent the nerve cell becomes, or the system becomes, on the presence of induced chemicals, and this gives you the answer, there are, in many ways, atrophying of other functions. Because the system essentially adjusts to artificial, levels, and other things which are underlying the original imbalance are not being addressed, and so that eventually either those problems will override the initial area that's being targeted, or the initial area will need increased levels of medication. So you get an atrophying effect because the really underlying issues are not being addressed.
Right, and it may not even be atrophying. It may be like they do find that there's increased receptor growth.
Right.
Okay. That, that more receptors are growing in order to handle this change situation.
Before Tim's done, just want to a couple comments. I think one of the things is that what this allows you to see is that the question is, how are you going to talk, whether you're developing a system that targets a specific symptom that can be traced to a specific location, or whether you're beginning to, Dr. Schiff said last night, I want to add, that one of the things that's happening in the field, right, is that, and I've dealt with a couple of neuroscientists at the university I teach at, talking about in the field of neuroscience, in the research, not the pharmacological method, just in the study of this, more and more of the interconnectedness of this, and of the interconnectedness of the whole system, the kinds of presentation, whether you call it orgonomic or whatever the name is growing much toward this totality of understanding of all the interconnectedness. The psychopharmacological industry, as opposed to the people who are studying the chemical and neurological aspects of this, are investing increasing amounts of money not in developing approaches to address the whole system, not just in terms of the one group of cells, but in terms of the whole organism, which is the direction where neurosciences is going. But the industry is moving towards developing more and more efficient ways of targeting even more and more specific sub-areas of the overall function to give it tighter and tighter targeting and control, which appears to be completely counterindicated to what the solution to the problem is. So that it's on, it would almost appear that every time, from whichever direction you come at, the knowledge begins to move towards a more broad-based understanding of how the organism works. The mechanistic society, which where all this operates in, right, and Reich was really in touch with that in terms of understanding the social implications, because it's not just this brain cell, it's not just the next brain cell or the next, or the whole, it's not just the segments of the body, it's that we then, in terms of our behaviors, operate in social systems that in many ways reflect the same issues that are going on here. And the result is that our behaviors become linked to and dependent on the influences. So one of the things that we call these mood-altering drugs is because they begin to affect our behaviors, and so it becomes a continuously self-fulfilling operation. And it's really fascinating because it's really clear that what has to be looked at is the whole interconnectedness of this throughout the whole organism.
Which is why Reich, toward the end of his life, came to the conclusion that the answer was not in individual therapy,
Right.
but the mass social scale is really where things should be addressed, because it's like just treating one segment of the brain rather than the total organism, and you can expand out from that.
Right, exactly, because it really is a question. And it's always a question that I'm with all the time. How much, I mean, even as we know more, even get more specific drugs, or even know more orgonomically in a technique way, how much of this biopathy can be changed?
And what's the origin of change? Altering chemical structure, or altering even the physical structure through chemicals or some intervention, does not necessarily get to the issue of what caused that contraction to begin with and whether that's repairable. But certainly part of what's going on here, which even the neurosciences don't completely address, is that this cell exists along with all the other cells in our organism in a soup, basically, in an energetic, which of course they don't acknowledge, but if in fact orgone energy exists, if there is this, cosmic energy, this biological energy, that something in any organism that has a disruption, it has to do with the ineffective maintenance of that energetic experience. So one of the things we haven't talked about here is, for instance, Reich's interest in the devices for increasing energy flow in terms of pulsatory energy, in terms of accumulators or door busters, different devices. That if in fact you increase the energy flow at the same time, enable the individual to tolerate and behaviorally deal with more flow, you might be also increasing the possibility of some repair or at least functional improvement. The problem is what Reich experienced over and over again is that very often, if it's advanced, far enough advanced, that you might get initial success, and then the patient begins to simply not be able to tolerate the expansion or the increase, and this is the constant problem. With medications, what I think we try to do in our practice realistically is at times use medications selectively at times when individuals need some additional support until you can build strength. In terms of the psychopharmacological world, forgetting orgonomy, the standard results have indicated over and over again that the use of medications is very ineffective long-term without extremely in-depth supportive psychotherapy of some sort. It doesn't have to be orgonomy. So that raises, the fact that they're responding to something that is genuinely generated by the critique that Dr. Schiff was offering.
That's what I want to ask about. When let's say a patient comes to a therapist and you need to put them on Prozac or something for a while, yet they want to have supplemental orgonomic therapy to help out also. Will Prozac or will a drug like that allow you to work on the ocular block?
Yes.
Yeah, so you're working on an ocular block that is altered by the Prozac.
But you can't work on the ocular block with some people without.
Right, but it's still allowed.
Yes. I have not found that a severe blunting of affect. I don't work with schizophrenics, so I haven't.
But anxiety disorder.
Yeah, I have not found with depression, a person, and it really seems that for many patients who really need these medications, there's so much difficulty in handling affect to begin with that it allows the brain to be able to contain some more energy. And it is therefore helpful. That's been found out in non-orgonomic treatment. You put a person on medication, then you can talk to them. Then you're not just talking to them about how they, are jumping out of their skin and they're having a panic attack and so on and so forth. You're able to talk to them about the issues because you've contained that energy. Okay? In the brain, you've contained it. Then you can work on the issues, and then you're teaching them, helping them from this vantage point. You're changing their biophysiology to be able to then function, and then they can get off of the medication.
And you might come off, what happens sometimes when you do this is the patient might come off, have to go back on through various, at times because of stress, but basically gradually what you do is you increase the person's capability to tolerate broader function without the use of medications, and it can be useful. I would add that in my experience, that it does interfere in the purest sense, in the sense that when someone is on medication, you're working through that. in a sense. But clearly, in Dr. Sobey, I had talked to him about this many times, said that you can't be philosophical about this. If somebody is so panicked or is so depressed that they can't get out the door, and they can't, they can't function, to say to them, well, you're just, there's no, until we can get through this, you just won't function, is not usually practical. And sometimes you have to introduce, things in gradual steps, and you have to take what you can work with step by step. That you can't be, there was a tendency in some. Anecdotally, there were certain early orgonomists, not Reich, by the way, but some early orgonomists who took the position in the most pure sense, the most famous being Dr. Silver, who was a fanatic in many ways, who said that you could. Remember, there's a famous story of his yelling at Dr. Sobey because Dr. Silver wasn't around. A patient of Dr. Silver's had a bad headache, called Dr. Sobey up. Dr. Sobey said, "Take aspirin." And the headache went away, and then Dr. Silver got furious, and they had a meeting with Dr. Reich, and Dr. Reich yelled at Dr. Silver and said, when somebody has a headache, you do anything you can to get rid of the headache, then you worry about what caused the headache. It's practical, it has nothing to do with, So the issue is, medicines are useful, right? But, for instance, it's demonstrable, many of you have experienced them, that someone has a migraine headache. We can treat migraines very effectively without medication. But if someone is in a severe migraine attack, you don't say, well, you can't take medication. First you treat the pain, and then you begin to deal structurally with the things that are causing the migraine. Same thing in this whole model. You don't deny that this is operative, and you work with it as best you can until you can address on a larger scale. We certainly orgonomically do not have the kinds of means of addressing all of this on a broader base. What is interesting, if one reads the treatment of the case example of the treatment of the schizophrenic in Reich's work, was that clearly he was able to demonstrate that without use of medication, one could possibly affect profound, maybe even more extensive changes and alterations than with the use of medication. Of course, at that time, he had patients and he was dealing with people who weren't medicated, who were hardly medicated. There was almost no medication. The other thing, which I just wanted to add quickly in terms of what Dr. Schiff is talking about, was the fact that what you begin to see with the flooding of the system with heavy medications in the area, we don't know yet what the results are going to be in terms of antidepressants and anti-anxiety drugs. We're only beginning because they become. But in terms of the antipsychotics, which are really profoundly, used broadly, what you see is that clearly the antipsychotic drugs, while they address certain disturbing behaviors and disturbing functions within the system, also produce profound contractions in broad areas of the rest of the neurological system, so much so that suddenly what emerged is a whole new area which has nothing to do with natural deterioration. It has to do with the chemicals themselves, and it's called tardive dyskinesia. And basically, patients who have been on long-term antipsychotics begin to present wide range of neurological disorders that have nothing to do with the original disease. Because what's happening, we understand now, is that while the antipsychotics are targeting dysfunctions here, they're also flooding and altering functions in the whole organism.
Essentially, the dopamine is the neurotransmitter that also has to do with these neurological disorders. So, if you've decreased, depleted, or stopped dopamine, yes, you want to stop it. You want to decrease the amount, at least the psychiatric situation in the schizophrenia, but you're doing it the same in the other areas of the body, and you lead to these tremors, which then become irreversible. I mean, that's the interesting thing, and the tragedy of it.
There's one thing that you said
Where did antibiotics come into this? You mentioned them and then not.
I
didn't mention it.
I threw it in, so he's not going to take responsibility.
Oh, I see.
I mean, antibiotics, it's interesting. We're not sure what impact antibiotics have on the brain, if any, but I suspect that the answer lies primarily in the fact that it impacts on the overall bioenergy system and biological function in the body, which in some way then in terms of blood flow and basic oxygen uptake and basic metabolism, both of of energy, glucose and other functions, but also impacts on uptake and metabolism of orgone energy, affects overall function in the brain. So that clearly most of us know when you're on an antibiotic, there's often initially within the first 24 hours of the antibiotic, and it's not just that the infection is being reduced, which is part of it, or the fever is being reduced, but there's literally a swell of energy. Problem is then there's usually a reduction of energy because the antibiotic then impacts the whole organism cellularly. But clearly that's, again, the new generation of antibiotics becoming, the direction in the chemistry is to go for more and more specific targeting. But again, as Dr. Shim said, you don't know when you get a specific area, what impact it's going to have on the whole system broadly.
And they can do more specific targeting. I mean, just, there's no doubt about it. And they can target, they will eventually target areas that don't just have to do with this. They'll target other, and maybe much more fundamental as they target it within a genetic kind of process. And but again, it's still target.
And those antipsychotic drugs you were talking about that have that extra, that danger part,
Yeah.
what are those?
You want to make sure
They're all similar to Thorazine,
Oh,
okay? And they have other names as well, but they're all affecting dopamine. And they haven't been able to, see, I guess the hope would be, to figure out, there's 2 dopamine receptors, there could be more. Like they're finding in serotonin, there's not just one serotonin receptors, I think there are 5. Maybe they'll find 10 as they keep it. And they're finding that it has a different effect, the serotonin, if it attaches to one receptor versus another receptor. What their hope is to be able to differentiate what receptor might have to do with the dopamine that could lead to tardive dyskinesia, what wouldn't, or also to be able to target more specifically the individual cells themselves, in what part of the brain. Now they can't do that. Maybe they will be able to, and maybe that's what a psychopharmacologist would say. Like there's a very excellent book by Sal Snyder called Drugs in the Brain, and he's a major researcher. He discovered the opiate receptor and so on and so forth. Writes very well, good book. But he comes from that vantage point, and his vantage point is we're going to have drugs that are just going to be able to do exactly what you want.
But the problem here, the caution here again, is what none of this addresses is what causes that dysfunction. And the attempt, of course, hand in hand with this, is to say that the causes are genetic, some genetic deformity, some genetic malformation, which don't address what caused the genetic dysfunction. Now the issue again, on a cosmic level, this is a similar kind of struggle going on in terms of looking at in astrophysics and the study of the universe. They keep getting the more information they get, this is the phenomenon, you get more and more information, more and more detail down to the most minute level, and you can target different, specific areas of the universe, or specific areas of the cell, the subcellular structure. But what happens is they're constantly at a loss to explain what unifies it all and what impact a pain in your back has on the way you think, or the fact that something, what is it that caused that? Let's assume it is. Reich accepted the fact that genetics played a major role in all of this, including schizophrenia. But what is it that caused that genetic malformation? We know now, for instance, alcohol consumption during pregnancy has profound impact. But it's reasonable to assume, if 30, 40 years ago, people wouldn't accept that alcohol, could cause an alteration. It's reasonable to assume that these alterations take place on all sorts of profound levels. If you remember the lecture, some of you were here with the hookup to the West Coast with Dr. Rothenberg, talking about cancers in young children, very early onset, 1 year, 2 years old, babies even. And what could be the origin of that? Well, the origin of that might well have been the energetic, experience of the fetus developing from an early cellular level in terms of the organism it was developing and the insults to the adult organisms, the host organisms, behavior. That these things are so, that what orgonomy, it seems to me, what Reich, forgetting the name, proposes is a unifying field, a unifying understanding for what, and so it just always strikes me that I think, and I remember talking to Dr. Sobel, I talked with Dr. Rothenberg, and Dr. Shimon, about that all of this growing information is extremely valuable, but it becomes more valuable if you can then organize it within a broader, in other words, it doesn't invalidate the work or the contributions of Reich or the understanding of orgonomic function or energetic functioning. It just tells you more about the mechanisms that this energetic function, this pulsatory function plays out through.
I just want to say that one of the things that you said to me was very depressing. Talking about the tremendous strides that the various branches of science has made in the past 5 years, 10 years, or 2 years, and the tremendous strides that are going to be even next year. Orgonomy hasn't budged. For 40 years, we know what we knew when Dr. Reich died, and it hasn't moved, and it's very depressing.
We've talked about this before. Dr. Rothenberg has mentioned this, is that one is that it's not going to budge on many levels. One, because of to some extent, because of those of us who are in the field and the limits on us. But the fact is, we do not have the structural systems in place to do extensive research. And I would argue, though, that it has budged. I think there have been people like myself, Dr. Schiff, others who are addressing some of these issues, trying to deal with Dr. Konya, others, Dr. Courtney Baker, Dr. Herskovitz to some extent, who are at least looking at what's happening in terms of what's the available research on all these levels and beginning to incorporate. There are also workers in the field who are not directly involved with orgonomy, which is one of Reich's great hopes. People, who are midwives or obstetricians who are using this kind of information to begin to enhance work, in other areas. So I think there is growth. The fact that orgonomy as a discipline, it remains on the margin of the clinical scientific world. Reich, Dr. Sobey's last remarks to me is that Reich didn't care whether it came under the name of orgonomy or not. The issue was that if the basic understanding plays out and becomes operative. So that the issue is, I've talked to neuroscientists who are beginning to get, and I think that's what Dr. Schiff is getting excited about when he reads some of this stuff. There are people there who are beginning to get, even within this more limited mechanistic structure, that there's something larger that has to unify it.
Well, I think when you look at what's happening in science, you see a great deal of cross-fertilization. You see a tremendous number of people working in their own ways and interacting with one another and building a whole base of knowledge. Orgonomy can't do that. Right. There isn't the energy. There isn't the people there. Orgonomy is just stuck, right, with drawing upon what these other people do because it fits, and then utilizing it. But there isn't a lot.
There's no institution, basically.
It's the people.
Yeah.
It's the people.
It's the structures of those of us who are in the field, and what's become of it.
In fairness, there's a big difference between billions of dollars and $12.
Yeah, but Reich. But by the way, the answer to that is Reich did an incredible amount with very, very little money. Because he had a group of, essentially had to do with his energy, had a group of people, it was a different time. But also, and this Dr. Sobey always like to say, is that they, of course, in those days would do research and do kinds of things that people, you get in trouble in this society. If to have your own laboratory and to do blood research today in your own laboratory, which Dr. Sobey did until 1963. Under New York State law, you can get closed down. You could lose your life. I mean, there's a lot of also conditions that make it harder. But I agree with Dr. Schiff that the big problem is that there exists in those who even concern themselves with orgonomy such factionalism, such resistance to collaboration, such resistance to joining together to build a broader base. And we're all at fault to some degree, and I think as long as that exists, there's very little hope for it to grow in that way. I think the level of growth that is possible is through education, is through groups like us, individuals who go into universities, talk, write about it, but it's going to be somewhat.
Yeah, for example, I think money is an issue. Like we can look in the brain now and we can see blood flow. Okay, we can see what areas of the brain get activated. What would it be like to be able to test that and observe that when a person is undergoing therapy? It would be fascinating. It would be really fascinating. But of course, there isn't the money, there isn't the expertise. There isn't the interest.
We should add, for instance, and this is another thing that has to do with the internationalization of this. In Europe, there are a number of places in Europe where people are doing more research along this. There are some people in Germany, some people in Italy who have been working on a broader base where there is more funding. There's some Latin Americans who have been doing more research, fundamental research like this, where the conditions for doing research are not as restricted because of litigious issues and such. The problem is that, again, because of attitudes, there's a resistance of various groups within the existing orgonomic structure to work that's going on there, or this group over here, or what's going on in Germany, that's not this, and back and forth. The last thing Dr. Sobey said to me, people think it's depressing, was that the best thing that could happen for orgonomy was for all the old people, all of the different factions to dissolve and die. Because then maybe people would begin to look at the work, and as long as Reich's work itself becomes basically survives and available, people can read it, respond to it. And there are many people in neurosciences who I've spoken to who have, on a limited basis, talk about, some of those ideas might actually have some basis, and they give some interest, although professionally it's not particularly, they're not drawn to it because it doesn't have to do with where their careers are, but there's interest there. A couple more questions.
No, I just want to make a comment. The fact that people are raised in our society in a mechanistic manner, in other words, they like to see, serotonin, there it is, that's the thing. People get that attitude in school, people learn that attitude, so to go from that to the economy and holistic attempt is a big leap, because what happens, say you're a scientist and you're in school and you want to learn about serotonin, you live up to 20 years, 40 years of your life studying serotonin. You get a lot of information on it, it's very helpful. But what happens is you forget about everything else, because that's what you spend your time on.
Right.
And you don't talk to other scientists about it because other things, because they're doing their other thing. But what they forget is that serotonin is affected by everything else that's in that system. And that's like when you have a drug trip. It's affected by everything else that's in the system. And you can't test everything else in the system. It's impossible to do it. There's too many variables. So if you took serotonin, you started saying, well, what happens if I put serotonin with dopamine?